it did really resonate with some of the challenges that we found ourselves under, especially as healthcare practitioners in the community at the primary site. You know, lockdown measures, when they were put, I think for us as practitioners and clinicians, we actually had to shake our heads to say, oh, wow, you know, we really now going to have to struggle to actually get our clients coming to the services. And some of the points that the survey actually highlighted are quite true, and they did actually impact on the service. And remember, with us in especially in South Africa, we are still using some targets, you know, that we need to achieve for us to be able to deal with some common health challenges that we have. So during lockdown, we did find that utilization of services really was clamped down. You look at access really for women and children became because mostly women and children were on the preventative side of most of these things through your expanded program of immunization that we're using in South Africa. Family planning, reproductive health that we're using in South Africa also did take a knock at that time, because some of the regulations that were put in place actually did close those preventative services out. And for us, it actually, you know, made it so difficult, because for long-term planning, we need to meet some of the sustainable developmental goals. And mother and child has always been a thorn, you know, in our backsides, because our mortality rate there, we really need to improve. So definitely in that aspect, we found that children were not coming to immunizations because those services were closing out. And remember, when children don't come to immunization, for us, it becomes a challenge, because even nutrition, we cannot even be able to guarantee that, because usually they would come for their well baby, we would check their nutrition status. So that also did take a knock. Some of the issues is that some of we are advocating for exclusive breastfeeding, you know, especially under the HIV. We are expecting for safe exclusive breastfeeding, and we do give mothers some of the ARTs, and also that took a knock. So definitely it would be lovely to see in terms of in a year or two what the numbers will be saying in terms of the outcomes in those lines. Mental health care, definitely being in lockdown, it was such a taxing, because it was a new phenomena for both us as the healthcare workers and for both even the society at that time. It was actually a taxing moment. We found that gender-based violence did actually go up in our country during the lockdown, you know, and also there was this stay at home, and some of these gender-based violence were not even reported to the authorities because of the stay-at-home phenomena that was going on during that time. Harmful use of alcohol, it went rife in South Africa, to a point where, because we were looking at the bed capacity, there was a time when alcohol alone had to be locked down. Restrictions were open, but alcohol alone had to be locked down during the time, because we were trying to actually relieve our casualties, our trauma. I think in at that side you call them the trauma units, accident and trauma units, because with alcohol we find that we'll get more accidents, and definitely we needed the oxygen, we needed the beds, we needed the ICU for COVID patients. Social vulnerability, it became, it hit us mostly because in South Africa, we do know we still have what we call child-headed households, you know, whereby children are taking care of their siblings. And during that time, we found that a lot of these children could not be able to access some of the social reliefs that were there during that time. And that impacted immensely into those households. Women also, remember, women in our country, we still do mostly what we call care work. You know, we are domestic workers. We are, you know, your care workers at the forefront. That's where you'll find female dominance. And during the lockdown and the stay at home and the social distancing, those services actually did take a knock. If ever we can never even resuscitate, because people lost jobs. So people could not even hire, you know, your social services to assist. So we did find ourselves that with the lockdown, you actually don't know, is it a good thing to close, especially under primary health care? When we look at the design of primary healthcare services, we found that it is more on a social one-on-one type of system, because we go to households. Now, when a lockdown says don't move, definitely meaning healthcare also cannot move. We couldn't move services. We couldn't move, do our door-to-door campaigns. We had to also shut people inside. You can imagine with tuberculosis, where we also advocate for, ventilation be out there. Then, you are having to say, stay at home, with that person in the house. TB also did suffer a lot because we even shifted and moved to concentrating on the COVID and pneumonia symptoms, and TB hit us at the back and it went up. So some restrictions and the restrictions that were imposed on us did adversely have an effect on the healthcare system. We'll wait to see in terms of, are we able to put contingency plans, or are we able to put recovery plans, improvement plans, so that we're able to get some of the systems that we lost during the period of the lockdowns and the restrictions. Do we need to be restricting healthcare service, specifically when we're trying to use the universal health coverage and primary healthcare as the core? How do you put lockdown on a healthcare and especially preventative services? Because what we focused on mostly was the curative and the palliative. So our rehabilitative services and preventative did take a knock during that period of the pandemonium that was going around.